Venture into the frontiers of healthcare data innovation with the Health Data Forum. Welcome to the Health Data Forum's YouTube channel, your gateway to thought-provoking conversations, cutting-edge insights, and groundbreaking advancements in healthcare data. Join us as we explore the transformative power of data to revolutionize healthcare delivery, patient care, and societal well-being. Embark on a journey of discovery. Delve into healthcare data through our informative videos, featuring leading experts, thought leaders, and innovators. Discover how our global movement, Data First, AI Later, is building a strong foundation for ethical and impactful healthcare solutions. Experience the collaborative spirit. Be a part of our vibrant community of health data enthusiasts, where ideas converge, partnerships flourish, and innovation takes center stage. Participate in discussions, share your perspectives, and join us in shaping the future of data-driven healthcare. Stay ahead of the curve. Stay informed about the latest developments in healthcare data through our comprehensive video library. Catch up on insightful interviews, thought-provoking presentations, and engaging discussions about the role of data as the backbone of healthcare transformation. Join us in shaping the future of healthcare. Let's harness the power of data to transform healthcare for the better. Subscribe to our channel today and become part of the Health Data Forum's mission and our Data First, AI Later initiative to make healthcare data work for everyone.
Talking about the RCT duplicate project and some of the work that we've done emulating over 30 trials at this point. It's a short presentation, so I'm only going to go over a few highlights of some of the lessons learned as we try to compare the results from using real-world evidence studies to try and emulate these trials and some of the difficulties we experienced and the things that we learned from when we missed, more or less.
That's amazing. And what are the challenges you face right now in your work as a researcher right now in this field?
Well, we're expanding our work. Duplicate, the project that I'll be talking about today, is based off of emulating trials using only claims data. So we have many more follow-on projects, which I can't say a whole lot about because I need to get FDA clearance. But there's projects that we're working on in the oncology space where we're working with specialty EHR data to try and emulate 12 oncology trials. We are also finishing up our work trying to predict the results of trials that were ongoing at the time that we actually conceived of the protocols and registered them. And those results hopefully will be playing out soon. We're also doing some emulations with pediatric trials to try and understand how well we're able to emulate those in children, which can be a little bit more challenging because kids often don't see the doctor as frequently as an adult with chronic comorbidities. So trying to deal with how to handle confounding or other factors is a sort of different challenge. And then we're also doing some methods development to try and we're calling it bench excal, benchmark, expand, calibrate. I'm trying to use some Bayesian methods to help after benchmarking against a particular trial, changing one thing and moving to a supplemental indication and use that information from the first stage to inform your emulations in a second stage. So it's sort of a bunch of the work that we're doing right now with duplicate that's still ongoing.
We are also waiting for the presentation to come here. As soon as you get them, let me know. as we are entertaining ourselves, also we're taking advantage of this presence of Professor Shirley Wang is fascinating. But what yesterday in the symposium, I also heard some questions about the impact. What are the real impacts from the work you conduct, and how can they best be taken advantage by?
Well, sort of moving outside of the duplicate space, a lot of my work has been focused on reproducibility and transparency. So a separate project that I worked on was called the Repeat Initiative, where we tried to reproduce 150 published real-world evidence studies, see if we could get the same results when we were using the same data and the same methods as reported by the original authors. And so what we learned from this, we try to put into future or additional work in terms of guidance documents. And one of the projects that we did after that was to take the insights about reproducibility from the Repeat project and put that into development of a protocol template called HARPR, the Harmonized Protocol Template to enhance reproducibility for database studies. And this protocol template, which brings in those insights about reproducibility, has since been endorsed by multiple research societies, as well as regulatory and HTA agencies, which is what I mentioned yesterday about the International Council on Harmonization, where the international regulatory guidance actually asks people who are submitting real-world evidence studies for regulatory consideration to use the HARPR protocol template if there isn't additional region-specific guidance. So that's one area where the work has been having an impact on how real-world evidence has been conducted around the world.
Oh, it's really amazing what we are just listening here, because tomorrow we are going to have the HTA session specifically, and this is obviously impacting not only the lives of millions, but also the budgets of all the governments who spend and try to spend the taxpayer money on technologies, and that in the end, no one knows how effective they can really be. So obviously, the work you are doing is can potentially have a potential great impact on better healthcare outcomes and obviously better regulation and better policy. I think, are we ready to go now with the presentation, Rui? We have. Are you presenting from Zoom? 2 minutes. 2 minutes more. Okay. 2 minutes more. I think it's good to take advantage of this time with you here on thinking about how do you think that your field is going to evolve with the impact of AI?
I think there's a lot of exploration right now with AI and trying to see if AI can define the exposure, define the outcome, define the phenotypes without too much input from the investigator. But it's still really early stages. I think the things that I've seen so far, like you've still got to go in and check and correct and fine tune measurements. But in terms of AI, in terms of extracting phenotypes and things like that, there's a lot of work with LLMs and natural language processing to try and expedite development of phenotyping, but you always still have to do validation studies to understand the performance characteristics.
But can you imagine a world where AI would have an impact on your work?
Definitely. In terms of identifying empirical covariates as well as the measurements, we're already starting to incorporate that into some of our work right now. But it's still early stages. I think in the future, it's definitely going to play a larger role.
Okay. Thank you so much for this interview. I hope you had benefited from this conversation. I think it will create a good context for the presentation that we are going to watch now. Our technical team is working hard to make this happen. And finally, I think you recognize your slides? Okay, good. Okay, thank you so much. And I hope you enjoyed this presentation. And let me look at how we are from time. We are okay on time. Yeah. Okay. Please, a round of applause. Mr. Shirley.
Duplicate. And RC2 Duplicate is a project that's been going on for over 5 years. And in that time, we've had a number of publications talking about the design and process for this paper, issues thinking about design issues versus bias, as well as results from 32 clinical trial emulations, which is what I'll be touching on today. But to set the stage, there has been historically concerns about the credibility of real-world evidence and questions of whether this type of research is able to generate valid causal inferences. And that's sort of encapsulated in this commentary that was published in the New England Journal of Medicine a couple of years ago called The Magic of Randomization versus the Myth of Real-World Evidence. And the position that these authors were taking was that these database studies just can't generate causal inferences because they lack randomization. And so they pointed to a couple of selected use cases where there was a trial and a database study that seemed to be asking similar questions, but got different results. And as a counterpoint to this, a team of international regulators wrote this commentary where their main point was that this sort of misleading dichotomy between RCTs and RWE is just not helpful. And that moving forward, it's not going to be RCTs versus RWE, it's going to be RCTs and RWE. So where does Duplicate come into this? Duplicate is a demonstration project. It's a series of studies where we're trying to understand and improve the validity of database studies for decision-making. And to achieve this goal, we had 3 interrelated aims. The first was to emulate 30 trials that had been previously completed, as well as to predict the results of 7 trials that were ongoing at the time that we do the database study. And what we're trying to learn here is if there had been a similarly designed database study instead of a trial, would we have come to the same conclusion? The second aim is to test a really reproducible process with the FDA to evaluate database studies. And the third is to look at factors that predict concordance in results. And for this, we had 3 predefined binary concordance metrics, as well as looked at correlation coefficients overall. Now, in a more typical scenario, if you were doing a real-world evidence study, you'd be able to think about a hypothetical target trial that would address your question of interest, and then design a database study to emulate that hypothetical target trial. And as you get into the weeds and understand your data, you might tweak the parameters of both your hypothetical target trial as well as your database study until you get to a design that addresses a question of interest and is feasible with the data that you're working with. Now for Duplicate, we're in a contrived situation because we aren't trying to emulate a hypothetical target trial per se. We're trying to emulate an actual trial that was really completed. And sometimes there are certain aspects of these actually completed trials beyond randomization that we just can't emulate with real-world data. This means that what we're actually doing is emulating a hypothetical target trial that may have some differences from the actual trial that was completed. And this may have implications for both the question that's being asked as well as the results. So in terms of our process, for each of our trial emulations, we did an active comparator and user design. And one of our first steps was to develop this target trial emulation table where we would lay out the study parameters, the key design parameters of the trial, exposure, comparator, eligibility criteria, follow-up, outcome, etc. And then we would try to come up with observational analogs for trying to measure those same concepts in the real-world data. And we color-coded these concepts based on how well we thought we were able to create those observational analogs to capture those clinical concepts. If after going through this process, we felt we couldn't capture those key study parameters well enough, then we dropped the trial from consideration and did not proceed with emulation. Now, for each of these trials, we used up to 3 databases. These were the Optum Informatics, MarketScan, and Medicare databases. These are all national claims databases in the US. And so developing the protocol was an iterative process. First, as I mentioned, we checked, are the key study parameters measurable? We checked, do we have at least equal power to the trial? And are we able to balance on key confounding characteristics? And as we were doing these data checks, we went through a review process, multiple cycles with the FDA to make a go, no-go decision. And if the decision was go, we would move on to the next step. But importantly, as we were going through these data checks, we never looked at the outcomes stratified by exposure. So there wasn't pre-looking or pre-inferential analyses. And it wasn't until we registered the fully specified protocol with details of our data checks conducted to date on clinicaltrials.gov. After that point, then we ran our primary, secondary, and sensitivity analyses. So here's a snapshot of some of our results from 32 trial emulations. The Pearson's correlation coefficient overall was 0.8, but if you zoom in a little, you can see that there's quite a bit of wiggle around that diagonal line that indicates perfect calibration of the results between the database study on the x-axis and the trials on the y-axis. So of course, when we see this a little bit of divergence from the perfect line of calibration, we want to understand why. But before I go into my examples, I just want to briefly talk about bias versus design emulation differences, because bias is what everyone is concerned about with these non-randomized, non-interventional studies. But design emulation differences in the design between the trial and the database study can also play a role in divergence in results. So what we wanted to do was explore the potential role of design emulation differences. So we split our sample into two groups, those where we felt there were fewer design emulation differences, and those where we felt there were more design emulation differences. The details of how we define this operationally are shown on the slide, but I'm not going to get into detail. So this slide shows you the results overall, as well as on the basis of the split of fewer versus more design emulation differences. And what we observe is that when there are fewer design emulation differences, meaning that the question that's being asked by the trial and the database study is closer, we observe much higher concordance in the binary agreement metrics as well as the correlation coefficients. When there are more design emulation differences, the results diverge more. But this is not too surprising considering when you have different design parameters, you're asking slightly different questions. So to illustrate this, I have three case studies that I want to touch on briefly. One is on the focus on the use of placebo-controlled proxies, another on time-varying effects, and the third on chance and other factors. So for my first example, this is about placebo-controlled emulation. And just want to point out that for the duplicate sample, about a third of the trials used placebo comparators. But when we emulated them, we didn't want to use non-user controls due to the concerns about intractable bias. So instead, we chose to use active comparators as placebo proxies. These are active comparators where we do not expect the drug to have an effect on the outcome of interest. So for this set of 4 trials, which are looking at DPP-4 inhibitors, that's a glucose-lowering agent used in diabetes, compared to placebo on the risk of 3-point MACE. There were 4 trials looking at different DPP-4 agents. In the database studies, we looked at DPP-4 inhibitors compared to second-generation sulfonylureas on the risk of 3-point MACE, where second-generation sulfonylureas were chosen as our active comparator placebo proxy because they had been shown in previous trials not to have an effect on 3-point MACE. Now, what we observe in the trials is decidedly null results across all 4 trials. However, in the database studies, we observed results of around 0.9 with confidence intervals sometimes including and sometimes excluding null. Now, what we think may be happening here is a poor choice of active comparator placebo proxy, because when we're comparing DPP-4s to second-generation sulfonylureas, it means we're comparing expensive new drugs to old, inexpensive drugs that have been around for decades, and there may be some channeling going on here that's related to socioeconomic status or other factors related to SES that are difficult to capture in claims databases. There could be other factors at play as well, but that was one hypothesis. Now, for this set of trials, which is also looking at glucose-lowering agents in diabetes, this time at GLP-1s and SGLT2s versus placebo on the risk of 3-point MACE in this set of trials. In the database studies, we compared GLP-1s and SGLT2s to an active comparator placebo proxy that had been shown in trials not to have an effect on 3-point MACE, but was used similar stage of disease and line of therapy. And that is DPP-4 inhibitors, which, as we just saw before, does not have an effect on 3-point MACE based on multiple trials. Now, when we did this set of emulations, what we observed was very closely concordant results between the trials and the database studies. And we think that a large part of this may be the fact that we are able to compare GLP-1s and SGLT2s to a much closer therapeutic alternative. because DPP-4s are similarly costly, similarly new, and used similarly in this diabetic population. For my second example, I want to talk about the potential role of time-varying treatment effects in understanding concordance of results. So for this example, I'll talk about Horizon Pivotal, which is a trial that was looking at zoledronic acid versus placebo on the risk of hip fracture in patients with osteoporosis. Excuse me. And in the database study, what we looked at was zoledronic acid versus raloxifene, where raloxifene was used as an active comparator placebo proxy. Now, you can see for Horizon Pivotal, we ended up meeting all three predefined binary agreement metrics. But you can see from this plot that it's one of the ones that's falling a bit further away from the diagonal line than some of the other points. And to get into that a little bit more, thank you. I just want to show you a little bit more detail here. So for Horizon Pivotal, it was a 36-month trial, and over that time frame, the hazard ratio was 0.59. In the database study, our follow-up was 18 months because very few people came back for a second annual injection of zoledronic acid. And over this 18-month time frame, the hazard ratio was 0.75. Now, if you look at the cumulative incidence curves for the trial, you can see it's really hard to tell visually, but it's possible that there could be some separation in curves with time-varying hazards. But we don't know what the hazard ratio would have been at 36 months in the database study because so few patients came back for a second injection. What we were able to do, though, was to digitize the image from the trial to get an estimate of what the hazard ratio would have been at 18 months, so aligning the time frame with that in the database study. And when we did so, we got an estimate of 0.75, where the result very closely aligned with the result that we observed in the database study. So this is something that we observed not only with Horizon Pivotal, but with some of the other trials in our sample, where there was this design emulation difference, where in the trial, there was long follow-up with time-varying effects over follow-up. And this was coupled with very low adherence in clinical practice. When we corrected for the design difference between the trial and the database study, we observed closer calibration and results. So some take-home points here are that it can be really difficult to replicate the results of a trial when the effect is delayed or time-varying in the context of low adherence in clinical practice. And a corollary of this is that something that is already well recognized, that patients in clinical practice may not experience all of the benefit that's observed in a highly explanatory trial. This has been called the efficacy effectiveness gap. For my third example, I want to talk about the potential role of chance or other factors. So this is the same calibration plot that I showed you before. This time I've color-coded the dots based on whether they were classified as having fewer versus more design emulation differences. If you zoom in a little bit, you can see that the blue dots indicating fewer design emulation differences tend to fall closer to the diagonal line than the red dots where there were more design emulation differences. But there is this one notable outlier right here, and this is the Einstein PE trial. To understand what's going on with Einstein PE, we also have to talk about Einstein DVT, because these were sister trials. They were designed in basically exactly the same way with one difference. And the one difference was that Einstein PE was focused on enrolling patients with pulmonary embolism, whereas Einstein DVT was focused on enrolling patients with deep vein thrombosis. And both of these trials were comparing rivaroxaban, a direct oral anticoagulant, to warfarin on the risk of recurrent venous thromboembolism. So because the designs were so similar, they were both classified as having few design emulation differences. Now, to show you the results in a slightly different way, you can see on the top here that for Einstein DVT, we mostly met our binary agreement metrics, whereas for Einstein PE, we did not meet any of them. Now, the trials both of them met the non-inferiority criteria that they were aiming for, and the p-value for homogeneity was 0.09, indicating that there's weak evidence for separation in results. But for Einstein DVT, you can see that the point estimate is around 0.7, and the confidence intervals only barely overlap null, whereas Einstein PE had a point estimate on the opposite side of null with wide confidence intervals. Now, the two database studies that we conducted both had estimates of around 0.7 with tighter confidence intervals because we had higher power that excluded null. As we were trying to understand these results, we did find this meta-analysis of 6 trials that were looking at different direct oral anticoagulate agents compared to warfarin on the risk of recurrent venous thromboembolism. And this meta-analysis generally found a modest protective effect of these direct oral anticoagulants with no heterogeneity for patients presenting with deep vein thrombosis versus pulmonary embolism. Now, obviously, this meta-analysis included trials that were looking at different agents in the same class, as well as had different design parameters. But I do want to mention that in this meta-analysis, they included the Amplify as well as the Recover-2 trials, which were trials that were also included in the duplicate sample. And in the duplicate sample, these were classified as having few design emulation differences, and we also met all of our binary agreement metrics for them. So with that said, it's really difficult to still understand the potential of chance or other factors that are driving this sort of modest separation in point estimates for Einstein DVT and P in the trial. But I would like to reiterate that the database study estimates were consistent with each other with Einstein DVT, as well as meta-analysis indicating modest protective effects and no heterogeneity. So some take-home points are that understanding the replicability of trial results with database studies, it really requires a lot of nuance, and binary agreement metrics sometimes can't tell the whole story. Residual bias and random error are always potential explanations when you observe divergence in results, but we also need to think about what is the question that's being asked in the database study versus the trial, thinking again about the efficacy effectiveness gap. And another thing that is true when we're doing these benchmarking exercises is that we're using a single trial as a reference standard. And when we do this, we also need to think about the uncertain replicability of a trial, even by another trial. Another point is that when we're trying to understand when and how database studies can complement RCTs, that we need to think about what is the target trial, that hypothetical trial that would answer the question of interest for the end user. Are they interested in evidence under ideal conditions or clinical practice conditions? So something that we tried to do with duplicate was meet this sort of triad of question, data, and design. We started by clearly articulating the study question and trying to address a similar question to the trial. We evaluated the fitness of the data through a series of data checks. And then we very transparently operationalized all of our study design parameters, documenting those before pre-registering them on clinicaltrials.gov. And what we ended up finding was that as a general conclusion, when the data are fit for purpose and with proper design and analysis techniques, these non-randomized database studies can come to similar conclusions about a drug's effects as randomized trials. But of course, the goal isn't just to emulate trials that have been conducted. The goal is to be able to generate complementary evidence and address clinical questions where, for a variety of reasons, a trial cannot be conducted. And as I mentioned before, there's more projects ongoing right now. We are finishing up our predictions of ongoing trials. We're embarking on emulation of 12 oncology trials, working on methods for expansion to supplemental indications, pediatric trials, and more. So that is all I had prepared.
Thank you so much, Shirley, for this incredible presentation.
Citizens in order to provide better health care and better interventions to promote their health. There should be some kind of, let me pull the topic to my field, public health information system that could gather all this information and that could link between healthcare providers, researchers, political deciders, that we can all see the benefits and the important effect that real world data can have in every one of our aspects.